Telehealth is a new way to enhance patient access to highly specialized care.
Using new technology, sophisticated specialists can help patients just about anywhere. So stay tuned.
We're up next.
Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. Today we're going to talk about telehealth with Dr. Andrew Keller. He's Chief Medical Officer with the Western Connecticut Medical Group.
Welcome, Andy. We're so glad to have you on the show.
Thanks for having me. It's a pleasure.
So maybe you can start off for our viewers by explaining a little bit about what telehealth is and how it all got started.
So telehealth actually started in rural parts of the United States where there was a need to communicate with patients over large distances. And so it was really what necessitated the invention. Telehealth is really the communication between patients and doctors, or doctors and doctors, using audio and visual components, much like FaceTime.
I was going to say that telehealth sounds like a telephone, and what's the difference? What added is it the visual component that makes telehealth so different?
Yeah, so Eric, the big difference between talking on a phone and telehealth is the ability to see your patient, face-to-face interaction. It adds a tremendous amount to the ability of a physician to interact with a patient and determine, the severity of illness and what type of illness the patient actually has.
It's funny because I've certainly used this in my own life. I remember my son was having a rash and he took a picture of it and sent it to me, and I was able to make the right diagnosis and get him seen by the right people. So, I guess with the availability of instant imaging and FaceTime, this is really a logical extension of that capability.
Yeah, it is, and it's very much like what you described, but instead of sending a picture and forwarding it, it's actually real time. So it's as if you and I were sitting here talking with each other, but we were 100 miles apart.
And so, from a practical point of view, in rural areas, patients would, say, present to a local emergency room or clinic, and that local emergency room might not have the specialist that the patient needed, but then could access that specialist pretty rapidly.
Right, and so that's actually how it took off for our medical group, is that we have 3 hospitals, and at one hospital we just didn't have the resources for taking care of psychiatry at 2 in the morning. So we started by implementing telehealth so that one psychiatrist in another hospital would be able to interact with a patient and help manage that patient without having the patient being transferred down and all the inconveniences of that. And that's how telehealth really took off across the nation. In places like Nevada or Arizona, the number of, let's say, endocrinologists was so limited, but you still needed to see an endocrinologist. And so telehealth was available to have that interaction without having patients driving 150 miles or being inconvenient. So it's all about patient access.
Well, that's what I was going to say. What a wonderful thing that is, too, because it brings the expertise really to the patient rather than having to have the patient travel long distances to get the care that's needed.
Right, and in this case, it brings the specialist or the expertise in a hospital setting to each, to a patient in another hospital setting. So that's really how telehealth actually started.
And I've heard this being used, for example, to run ICUs in rural locations where there may not be 24/7 coverage of critical care doctors.
Right. So that's the EICU is what they call it. So even if you have an intensive care doctor in the hospital, even then, still having someone monitoring the patient has been shown to actually reduce, adverse events. So
it's really interesting because I think, we think in terms of projecting physician expertise long distance, but we forget about the 24/7 aspect of the need for highly specialized coverage. And we've handled that in medicine sort of in an ad hoc way. We take call.
Right.
So you work a full day, and then somebody needs to be available that night. But then as you try to expand that level of expertise 24/7 to 33 hospitals, it becomes actually quite cumbersome and extraordinarily expensive to make sure that that's available. And this begins to address that, doesn't it?
And it does, and it's not just even expense, it's feasibility. So when you have, let's say, a patient with a stroke in the Norwalk emergency room, and that person needs to be evaluated immediately by a neurologist.
There, time is brain. We know that we need to
Right.
intervene in some instances very, very rapidly.
In minutes, right.
Yeah.
And in order to do that, The doctor who might simply just be at another hospital has to go and travel on 95. Well, it's 8 o'clock in the morning and just can't get there in 10 minutes. It's an hour. And that's precious time for the patient. So this really, I think, helps cross that when you need to have someone there right now, and that it supplants having to actually drive. So it has a lot of significant advantages to cross time, so to save time, and also to save geography and having people move over long distances.
And it also, I think, allows us to bring, again, the highly specialized expertise on site at unusual times of the day and night. And I'm just thinking about one of the ways, this is not telehealth, but teleradiology has been around for quite a while.
Right.
And it's really sort of the beginning of this idea that it used to be in the middle of the night, the emergency room physician would order a sophisticated x-ray, and he and or a PA would make the preliminary interpretation and then base their care on that. But now we have contracts with people in Australia where it's noon, and they will do, so you get a radiologist to read it. But so we've seen that actually for several years.
And it all enhances care. I mean, it's all good. There's a large cultural gap too that that's one of our challenges, is overcoming the culture gap. That my doctor is right not next to me, right, but how do I deal with that as a patient or a family member? And that's part of the challenge.
And maybe you can talk about that a little bit more. I think as a viewer I might be wondering, well, if I'm having a stroke, is having a neurologist who is not physically right there with me as good as having a neurologist who's right there?
And so considering the time factor, it's better because you have someone there right now when you need them. And that's the whole point about 24/7. If it's 10 o'clock in the afternoon or in the morning and I'm in the hospital and I can walk down, great. But the odds of you coming in with a stroke at 10 o'clock is actually not that high. And you'll come in at off hours, and that's when you really actually have a great advantage. So that's how you try to overcome that cultural change.
And the need for that is driven in part by other technologies with which we can intervene very quickly and effectively for patients with stroke or heart attacks. But as you said before, the time is really the issue. So we have really new therapies for stroke patients.
Right.
So we can intervene in an interventional way, kind of get a clot out, for instance.
Right.
But making the decision to pursue that is very time dependent. So having the neurologist who can remotely assess the patient and say, yes, you're a candidate for that procedure, trigger the downstream channels to make that happen is really a big advantage.
Right. So and we've actually, so I'm a cardiologist, and we've known that in cardiology for a long time. When we started to actually put EKG machines in the ambulances and actually doing it in a patient's home, by the time the patient came to the emergency room, we were all ready to take them and open up the artery that was blocked. Same thing with neurology, same thing with stroke.
It also seems, in addition to be able to provide expert care in real time in emergent situations, that it also, and I think particularly for some of the rural hospitals and large distances that we see in the Midwest and the West, would allow a critical access hospital, one of these hospitals that sits in the middle of nowhere, to be able to have an endocrinology expertise or nephrology expertise. So you don't have to necessarily transfer the patient as early as you would otherwise have to do it, and you can get a much fuller array of specialty care.
Yeah, and the government actually recognizes that from Medicare and has recognized that for a while. So they've supported telehealth, and if you go to the website and you look at telehealth under the government sites, you'll see that really their first foray into it was just that, providing services to remote critical access hospitals.
Maybe you can tell us a little bit about the integration of other technology in the care of that particular patient. So for instance, laboratory data and imaging data in real time while the physician is also seeing the patient remotely.
Yeah, so there's various models of trying to integrate technology with telehealth. There's a kiosk model where the patient actually can go into a kiosk and there's a machine that you can put in the ear and look at the ear or measure a blood pressure in addition to whatever you get from the face-to-face interaction. In some of the other models, like in remote clinics, there's a stethoscope model. So there's actually a robot almost that will come in and has a stethoscope and a thing to listen to the ear, and a nurse or an assistant can place the stethoscope on the body, and the fidelity is excellent, and the physician who's 600 miles away can basically do an entire exam as if he was sitting there in the room with you. So technology is integrated. Again, in that setting where you're in a rural state, that's great. In Fairfield County, it's probably less of a concern.
But that neurologist who might be at home could be seeing the patient on a screen,
Right.
and also have immediate access to any labs that have been drawn in the emergency room,
Right.
have access to the CAT scan images that may have already been done, so be able to integrate at that level.
And we're moving that around now, so that's not new. You can be at home and you can see everything, but the one thing you couldn't see was the patient. So that's where this really makes
And
a
again,
difference.
as the demand for highly specialized care increases, and it continues to increase as our care becomes more sophisticated, it allows these specialists, I think, to expand their ability to cover more than one hospital or two hospitals. You could have a group of specialists covering 5 hospitals, and with these networks, that gives us, again, we don't have 5 tired doctors walking around. You only have one tired doctor walking around. I think
Right.
it's good for the patient in that respect. How about from a confidentiality standpoint? We all hear about hacking and getting in, and I guess particularly we talked about psychiatry. That might be a particularly sensitive area. Are people uncomfortable with the idea that their information is going to be compromised, and how do we protect that? This is obviously not a FaceTime call that is
Right.
available to everybody.
Yeah, so we don't use FaceTime. We don't use Skype because of those concerns. We use proprietary software that's hard-coded and is not something that can be broken into. The amount of effort that one would have to do to break into the technology that would use is so great, the benefit to whoever was trying to break in would be so minimal, there's really no reason to even do it. So we use that type of technology. And people have concerns. I mean, there's always concerns about, even talking on a telephone anymore, or, typing a text message where that will end up somewhere. We don't record the video, and none of the telehealth applications record any video or audio. So it's live, it's like a telephone call, it can't be retrieved. It's very much like you and I were sitting in a room together. We don't record these conversations, we don't record telehealth.
Now, the doctors do create medical notes about these encounters, do they
Right.
not? So this is a real visit. This isn't just a
It's a real
casual
visit.
conversation.
Right. It's a real visit. So if I was having a telehealth visit with you, I might be entering on my computer. If I was having a visit with you in the exam room, I'd be doing the same thing.
Yeah, we have some more information on telehealth. We're going to bring up a graphic so patients can learn more about this. Where are we using it right now in the Western Connecticut Health Network?
So we're using it in crisis intervention. So when patients come into an emergency room in New Milford Hospital, they can be seen immediately by licensed social workers or psychiatrists in Danbury Hospital, and it saves having to be transferred in order to be evaluated. And we're also piloting it now for stroke in the Norwalk Hospital.
And wonderful. I can see this only expanding over time because, again, it brings that expertise there when you need it,
right.
At the highest level of physicians that haven't been stretched so thinly that they're barely holding on.
And it's a slow process because of the culture change. People really need to feel comfortable with it.
Well, we're so glad that you've come on the show today to help explain to our viewers.
It's a fascinating topic. It's how technology is changing medicine very, very rapidly, amazingly so.
Well, great to be here. Thank you.
Thank you.
Well, thanks for coming on Health Talk today. For information on the Western Connecticut Health Medical Group, please visit us at www.wchn.org and click on the Medical Group tab.
Thank you so much for watching Health Talk today.
Be well.